Greetings from the University of Utah, Salt Lake City. It's an honor to be here presenting at the Chicagoland Radiology Expo. I want to thank Dr. Thomas Kim for inviting me. I'm Richard Brown, and my subspecialty interest in radiology is nuclear medicine. So let's get started. Disclosures, I'm a member of the Covera Health Medical Advisory Board, no other significant disclosures. And the question of the day to start with is, what is nuclear medicine? Nuclear medicine is a medical specialty which utilizes radioactively labeled molecules for the diagnosis, staging, and treatment of disease. So how are nuclear medicine studies performed? Radioactive tags are attached to molecules which localize to the body based on blood flow, function, metabolism, and receptor binding. Let's look at an example of blood flow. This is a cardiac myocardial perfusion imaging study, which is used to detect coronary artery disease. The patient is injected with a radiopharmaceutical at stress and at rest, and we look at the relative blood flow. So for those of you, which is probably most of the people in the audience where this is new to, there should be a complete circle around the heart, the anterior wall, inferior wall, septum, and lateral wall getting almost equal flow. We see that at rest, but not at stress. At stress, we see a defect or decreased activity in the anterior wall and septum. We also see that on the computer-aided diagnosis as an area of decreased activity at stress, which appears normal at rest, consistent with ischemia. This was confirmed with a coronary artery angiogram showing a left anterior descending stenosis. Function. One of the common areas we use nuclear medicine for is to evaluate the function of organs. And this study is called a HIDA study. It's used to evaluate the function of the gallbladder. We inject a radioactive pharmaceutical that localizes to the liver and then is excreted in the biliary tree. And as you can see the slide where the arrow is indicating, we see the biliary tree here, a little bit of bowel activity, but no real gallbladder activity. When we apply the fusion imaging, the CT, we can see that the gallbladder does not have any activity. And this area here is actually just duodenum. So this tells the surgeon this patient has acute cholecystitis. Let's look at an example of receptor binding. This is a dopamine analog which localizes to the basal ganglia in the brain. It's used to diagnose diseases such as Parkinson's disease. The slide on your left demonstrates a normal distribution of uptake in the brain. And the slide on your right is a patient with Parkinson's disease with diminished activity in the posterior aspect of the basal ganglia. Metabolism. Radioactive glucose is used in the staging and evaluation of response to therapy for various cancers. This is an example of a PET scan, and you can see the areas in bright yellow here are areas of tumor. This is just normal heart uptake, and I'll talk about how we use PET scanning in a minute. So how does nuclear medicine differ from diagnostic radiology? Radiology detects disease by alterations in the structure of tissues, for example, distortion of anatomy. And this is a patient with a brain tumor, and you can see a very subtle change, maybe impression on the ventricle here on the CT scan. MRI scan with a water-sensitive image demonstrates there's edema, but the PET scan with radioactive glucose demonstrates that the tumor is viable and still active. So in diagnostic X-ray radiology, X-rays, sound waves, and radio waves are used to create the image. They're something that's put into the patient, and how the patient's tissues respond to that and reflect it back or transmits the activity tells us what the anatomy looks like. In nuclear medicine, the tracer localizes to structures based on flow, function, metabolism, or receptor binding. So what are some of the commonly ordered studies in nuclear medicine? Here's a list that's not comprehensive, but includes many of the commonly ordered studies. And PET scans probably account for about half of our work these days. Bone scans, heart scans, hepatic or liver functioning studies, thyroid studies, functional brain imaging, and I'll show you an example of that, lung scans, tumor marker imaging, and radioactive therapies are becoming very important, what we call theranostics. So form and function. This is an old style nuclear medicine image, which probably gave us the moniker of unclear medicine. This is a radioactive iodine study. Patient had surgery and there's some residual thyroid tissue. This is a normal biodistribution. And if I were to tell the audience that I think there's a metastasis here in the left iliac bone, people would probably say I'm crazy. I'd never go into nuclear medicine. But to prove it to you, we got a CT scan and you can see that there's an obvious lesion here. Maybe you can't see it. But when I apply fusion imaging, both the function and the form, the lesion lights up like a light bulb, making nuclear medicine a very definitive study in diagnosing and staging the extent of disease. So form and function. This is a quote from Frank Lloyd Wright. Form and function should be one, joined in a spiritual union. And that's kind of how I feel about nuclear medicine imaging with SPECT CT, PET CT, and even PET MRI. So let's look at some examples. Power of fusion imaging, PET CT, form and function. CT is great for detecting disease when it alters structure of tissue, i.e. mass or density changes. FDG PET, radiolabeled sugar, locates disease by detecting changes in metabolism. And in looking at this image here, it probably would be pretty hard for most of us to detect where the disease is on the CT. Now you can imagine there's a little bit of soft tissue fullness in the deltoid here on the left relative to the right, and maybe something going on in the pelvis here. But when we apply the fusion imaging, the radioactive glucose localizes to the cancer, really helping us to stage the extent of disease. So what's the teaching point here? PET can detect disease, which is occult on CT and does not have the risk of intravenous contrast that CT has. This is a patient with lymphoma, and you can see these areas in black and going into the supraclavicular region and the axilla, the mediastinum in the abdomen, and in the pelvis and inguinal areas consistent with disease. So what makes PET useful? We could probably see this on a CT scan. Well, when we do the fusion imaging, we see that one of the areas of uptake is the left testicle. And when there's testicular involvement in lymphoma, that really changes the management. These patients then need an additional course of therapy or two, and they also probably need intrathecal methotrexate. So this is an example of how PET CT can change the management of disease. This is a patient with breast cancer, and we can see that there's disease, there's some post-surgical change with some inflammatory change in the axilla from the surgery. There's a lymph node in the axilla, some in the internal mammary node, supraclavicular. There's some liver mets. There's some bony mets. But PET CT imaging has many layers, and you really have to peel the layers like an onion. So tumors are hot on PET, but notice the distribution of disease as I just described. However, if you window the images and change the contrast, you can often detect disease in areas that would otherwise be occult. And you can see in this patient, by just windowing the image, we can see that there's fairly extensive metastatic disease in the brain. So nuclear medicine is not a stagnant field. We have a lot of tracers that have come on board in the past few years and several more that are coming on board shortly. This is a prostate cancer staging agent, which has been recently approved. There's a prostate cancer staging tracer in clinical trials and a neuroendocrine tumor staging tracer, which is actively in use and commonly used in our department. So let's look at some examples. This is a patient with prostate cancer, evaluate for recurrence. And this is a cross-sectional CT through the abdomen. You can see the kidneys here, the psoas muscles, IVC, and aorta. And this is a coronal image. You can see that there's some lymph nodes adjacent to the aorta. They're really small lymph nodes. By CT criteria, these would not be metastases. However, when we look at the PET scan, all those little small lymph nodes light up like a light bulb, telling us this patient has metastatic prostate cancer. The question is, which of these lymph nodes are positive if we wanted to perform a biopsy? When you perform the fusion imaging, you can see exactly what lymph nodes are involved. And these would be non-diagnostic by CT, and as my lawyer sons say, dispositive on the fusion images. So with fusion imaging, the location of disease really becomes obvious. Also, one of the intriguing things about nuclear medicine, since we're looking at metabolism and function, is the history is often on the images. This is a patient who had a history of prostate cancer, and they're asking us to restage the patient to see if there is recurrent disease. And you'll notice that the spine is hot or radioactive down to the level of the lower lumbar spine, but the lower lumbar spine and sacrum, as well as the medial aspects of the pelvis, are not radioactive. This is a radiation effect. So we can tell the patient had radiation therapy as part of their treatment. As I said before, the history is on the images. This is a patient who had bilateral renal transplants, and they're looking for post-transplant lymphoproliferative disorder, a type of lymphoma. And you can see the transplants in the pelvis. And then there's all this funny activity in the head and neck region. Well, that's not a typical location for metastatic disease. And this is the type of thing we would see if the patient was chewing gum while they had the tracer on board. You see the muscles of mastication and the temporalis muscle. So it's not to be worried about, but it does tell you that the patient was non-compliant, and didn't follow the instructions about being NPO before the study. Nuclear brain imaging, this is an area that's very dear to my heart. I showed you earlier the example of the dopamine receptor imaging used to diagnose Parkinson's disease. We also look at brain metabolism to diagnose things like seizures, tumors, and dementia. So let's look at an example of how this is used. But before talking about the evaluation of PET for dementias, the question is, why do we even need to do it? Dementias can be difficult to characterize based on clinical presentation alone. Alzheimer's disease, which is the most common form in adults, but accounts for only 50 to 60%. And comorbid conditions such as depression and medication can also confound the clinical assessment. So this is the evaluation of a patient with suspected dementia. We inject them with radioactive glucose, and the areas that you see in purple and blue are areas of decreased metabolism. And this is a computer-aided diagnosis that's showing us those areas. And as you can see, this is a surface rendered view of the brain. The posterior temporal and parietal regions are down bilaterally. There's also decreased activity in this portion of the brain, which is called the posterior cingulate, and this area, which is called the precuneus. This is a typical pattern of altered cerebral metabolism that we would see in a patient with Alzheimer's disease. This is not depression or medication use, so we can more appropriately treat the patient's symptoms. Well, another application technology that we use in nuclear medicine is SPECT-CT. So what is SPECT-CT? It's a single machine that combines a nuclear medicine camera with a CT scanner. Images can then be displayed side by side or in a fusion mode. This enables precise anatomic location of the source of the radioactivity. So let's look at some examples of where SPECT-CT can be useful in the management of patients. This is a bone scan in a patient with prostate cancer, and we can see an area here with some relative increased uptake in the lower thoracic spine. So we got a correlative CT, and you can see that there's some arthritic change in the costovertebral junction region, and that likely accounts for the uptake. However, when we apply the fusion imaging, we see that the uptake is not in the costovertebral junction, it's in the vertebral body itself. This is a metastasis, and we can say so definitively. Let's look at another example. This is a SPECT of a bone scan patient, again, with suspected prostate cancer. We can see some uptake here along the posterior elements. Maybe it's in the facet joints. Again, there's some degenerative change here. When we apply the fusion, you can see the uptake is in the costovertebral junction, and this would be consistent with degenerative change. The patient does not have a metastasis. It's also used in the evaluation of back pain. And for those of you that are still awake during my talk, you can see that there's an area of uptake here in the lower lumbar spine. And we got a correlative CT, and maybe those of you who are astute radiologists already have already figured out what's causing the pain. It's this area here. It's a pars defect. However, it makes it a lot easier to detect when you look at the fusion imaging. So occult fractures such as pars defects become highly conspicuous with SPECT-CT. This is a 63-year-old female with a history of hepatocellular carcinoma evaluate for metastasis. And we can see that there's uptake over the medial aspect of the right iliac bone or sacrum. And there's also these other two areas. Now, you wouldn't expect metastasis to occur in a linear fashion. It really makes you think more of trauma. However, do we really see a fracture line here? Let's look at the correlative CT. Correlative CT looks pretty unremarkable at first glance, and I'll give you a second to see who can detect where the fracture is. When I apply the fusion, you can see the fracture becomes very obvious. And this is really the power of fusion imaging. What about tumor localization? This is a patient with suspected parathyroid tumor, and we see this area along the posterior aspect of the left thyroid lobe. We apply our radioactive tracer that localizes to parathyroid adenomas, and this lights up like a light bulb, really directing the surgery and minimizing the surgery time because they don't have to go hunting for it. They know it's posterior to the left thyroid lobe. Here's another patient with a suspected parathyroid tumor. And you may say, well, maybe we have a parathyroid tumor in the chest. If that's the case, that's a whole different approach than in the neck. So let's apply our parathyroid imaging tracer, and you can see it lights up right in the anterior mediastinum prevascular space. It really helps the surgeon localize the adenoma and directing the approach to surgery. Function. This is an old style nuclear medicine study. Again, we started out with a slide like this showing a patient who had thyroidectomy and had maybe this patient probably has some recurrence in the neck. And we're deciding what to treat the patient with. And we see this activity in the pelvis. So if there's distant disease on these studies, it really changes the amount of radioactive iodine we treat the patients with. If the disease is localized, we may give 50 or 100 millicuries. If it's distant like this, we'd give 200 millicuries. So we got a correlative CT to see if we could see where the metastasis may be. And does anybody see the metastasis? So we have the form here, we have the function here. When we combine them, we see there is no metastasis. The activity is normal clearance into the bowel, and this happens to be a small inguinal hernia. So this patient does not have distant disease. We change the patient's management. So again, I want to thank Dr. Kim and the Chicagoland Radiology Expo for inviting me to speak. I also want to give a plug to the University of Utah Department of Radiology and Imaging Sciences. This is a slide of our campus. And at the bottom of the slide, you'll see a video link that describes our residency, interviews with our residents, and you can learn a little bit more about our program. I hope I've interested some of you in radiology and specifically nuclear medicine, and look forward to following the careers of those that come along. Again, thanks again, and I will open it up to questions.